happy to be here with you today to discuss migraine and cognitive dysfunction with Dr. Gil-Gouveia, who has been publishing a lot on this, and I highly recommend you reading her papers for more information. And you kindly are doing this interview before your talk tomorrow. We're very excited for your talk. Can you please tell us about what you're going to talk about?
Thank you, Olivia, for the opportunity to give this interview and to talk about the cognitive effects of migraine, which is my main research interest. So in this talk, I will only focus on cognitive changes during the migraine attack, not all through the migraine's lives. And because they're very relevant to the patients, because second to pain, they're the main cause of disability during the attacks because of its impact on everyday activities like working, driving, paying attention to things. So this is really, really important for patients. So it's relevant clinical information.
Extreme importance. And can you please tell us more about what type of cognitive dysfunction, and does it change between the prodrome, the headache phase, the postdrome?
Yeah, actually, what we found out is that cognitive symptoms are present through all the attacks. So they start with the other symptoms slightly in the prodrome, mainly in the prodrome, then increase in their frequency during the headache phase, and then decrease again in the postdrome. But they pretty much cover every part of the attack. So they seem to follow what the brain dysfunction that occurs during the attack as the other symptoms do. And so what is mainly relevant is that the type of cognitive dysfunction. So mainly the main cognitive symptoms that people have relate to executive symptoms. So cognitive processing efficiency, processing speed, and attention. This is a very, very relevant issue. Also, a little bit of memory and language complaints, but mainly executive dysfunction.
Do we have any idea why, from a pathophysiology standpoint?
Well, that's the great question, and you have to see my talk to know that. But of course, there's not a lot of research during attacks. It's difficult to do because it's difficult to put patients inside the scanner during an attack. And we like to study episodic patients to be able to clearly distinguish headache phases and headache-free phases. And we like to study spontaneous attacks because we don't want any pharmacological interference with the brain activation. So we've been doing some studies on women with menstrual-related migraine, and we're dwelling with the results now. So I'm going to present some preliminary data that is interesting. It's not completely done yet, but we found some interesting stuff. So you should go to the talk to
talk
learn
about
more.
a teaser. I just cannot wait for tomorrow. No, that's wonderful. And do you have any insights or ideas about therapeutic options, whether pharmacologic or neuromodulation?
Well, we haven't done any work on that part yet. So I think trying to understand the brain processes underneath these symptoms is relevant also to try to understand how we can help these patients, because as we know, most medications that we have that do control the attack or the pain sometimes do not control the other symptoms. And so there's been a major, I think, breakthrough in the last trials, because besides the attack, the new drugs are testing the most bothersome symptom, and this is the effect of the drug on the most bothersome symptom, and this is very relevant. But we're very far away to know what will happen and how we can influence this in a positive way. So return patients to full function as soon as possible. The only thing that we know from clinical experience is that some drugs might sometimes increase cognitive dysfunction. It's like triptans. Some patients do report that. Then when taking triptans, they get slower, they get pain-free, but sometimes get even slower and with more difficult functioning, executive dysfunction.
Yeah, and there must be the finding, understanding the pathophysiology, finding the right treatment, and also probably the timing too.
Yeah.
Because the cognitive dysfunction starts oftentimes with the prodrome. So when is the optimal timing to try to treat too?
But the point here, if we can fully understand what the differences are, and I can, you can imagine, because there's a lot of brain imaging data outside of the attacks, that there's a lot of changes happening in migraine brains that are different from healthy controls, that we can learn how to modulate, and maybe with neurofeedback techniques, or we can try to help these patients, teach them how to control the symptoms on the earlier stage.
Yeah. That's wonderful. Thank you so much. We are so excited for your talk, and thank you for doing such important work and research that's going to help be very impactful for patients and the ability to function. Thank you.
Thank you.